Okay, I'll grab everybody's attention. We're gonna go ahead and get started. Thanks. There's like 16 people on Zoom. This is good. So this morning we're going to first talk about this Mepilex trial. Just an introduction and some detail, and then we have Lee here from the company that's going to do a demonstration for us. Those of you guys on Zoom, I'll try to turn the camera. And I'm recording this so we can share with everybody throughout this next week. After that, we also have our resident in service, just to segue into the whole concept of pressure injury prevention, why it's important, and what our role is in the perioperative area. So anybody on Zoom, if you can't see the screen move forward, please let me know in the chat, because I feel like we try this every week and sometimes it works, sometimes it doesn't. Also, if you can't hear me. Okay, so Serena and I put together like just a few slides about the trial itself. We are working with the operating room pretty closely. There was an SBAR developed. I'm not going to read through this whole thing, but essentially UHOR has no formal pressure injury prevention guideline. This has been like years of, we did maybe a trial, I think it was back in 2018. A handful of services were on board, but then COVID hit and things kind of fell off the train. But now we're really trying to narrow in to have a true guideline, which then rolls into, we're going to do a trial, see how it works. And this is hospital wide. Lee and his team are educating the entire hospital, the floors, the ICUs. So everybody's on board and invested in this. So what are the key things that we need to know in pre-op? So again, a little bit of background information, from a AORN and like PACU perspective, pressure reducing services, correct positioning, padding, elevating the heels, and then prophylactic dressings. Our goal is to identify those people at risk. And then if anybody is at risk, we're going to do a preventative measure. But then there's also those people that have existing, maybe an ulcer started, whatever, that we need to segue into a treatment. So just a little statistic data. You can't see it. Okay. Wait, let me see. Does that change it? You guys can't. Yeah, that was it. Okay. Now there's always like one thing that I have to flip. Okay, so just some stats, 20 to 30% of our patients, get rid of this. In a skilled nursing facility are affected. Even 60K patients are, this leads to death on an annual basis. An average 4 days longer length of a hospital stay. That's why we're like queuing in on this, how we can prevent it. Pressure ulcer prevalence occurs in a rate of 8.5 or higher. And these are all like Google statistics. I'm sure you can give us some more evidence-based research as well.
Second most prominent lawsuit is pressure causes death. First is like leaving stuff in the cavities. Second is wrongful death due to pressure.
It's kind of scary.
It's crazy.
Yeah. So think of your loved ones every time that they are in a hospital or whatnot. Like, we have to be very diligent about preventing this. So what does the trial include? The patient population we're starting with is the urology patients. There is this criteria that was put together in combination of the OR staff, some of our PACU leadership as well. This may fluctuate a little bit. but essentially cases longer than 2 hours. If they've had a previous injury that poses, a higher risk, patients with underlying conditions. We all know all of our patients have a ton of comorbidities. And then, patients at risk for friction and shearing or injury, presence of redness on the sacrum, coccyx, or heels that are already there. So again, I know we all we try our best, but it's so important to look at your patient's skin in pre-op and in PACU. If we can catch it in either area, hopefully we can prevent some of these, hospital-acquired injuries. So if they meet the criteria, again, specific to these urology patients, some of the OR educators are going to screen ahead of time, like 24 hours ahead of time, look at their chart, and they'll indicate and coordinate with Mary Ann's team, the phone callers, as well as the charge nurses, and put it in the special needs section that this is a urology patient that qualifies for Mepilex. Are we going to get every single one of them? Hopefully. But that's right now going to be the communication. After that, we'll go into a few more details about then if the charge nurses and pre-op, hopefully, they're going to look through that screen. They'll be able to go and grab the supplies first. That way, then the nurse knows. But it's going to be a combination of the pre-op nurses and charge nurses communicating of if it's a urology patient and if they qualify to put the dressing in place. So I'll have you go ahead and just do the demonstration of how do you apply this and the concepts of the product itself, and then we can talk a bit more about documenting it.
It's strictly urology, not like urogyn, just urology, right?
Yes, for now.
Uro was the most receptive to helping with the trial. But a little background with it, you want to stand?
Yeah, if you want to.
A little background.
This is Lee, sorry.
I'm Lee. I'm your rep from Mundlicka, easier said, we're the Mepilex company. Little background on this. The preventative dressing, specifically the sacral, has always been a constant in the ICU. Conversation started with Rachel Orphy, who is a CNS on 5, and also Margaret Fast, who has moved on. But we were looking at pressure injury data as it pertains to the ORs. And the OR pressure injury data was markedly higher than the rest of the ICUs. And me putting two things together, I was like, well, they have a pressure injury prevention program in the ICUs, so obviously their scores are going to be lower. So that being said, we were able to push a trial out on 5C with the sacral dressing. I believe, don't quote me, that was back in April. Instances of happies were driven to 0. They've had 0 on there. So that being said, we're waiting for final approval from the executive leadership team to push it out to the general hospital. I'm 99.5% confident that that's going to happen, which is why we're doing this, okay? Because it's going to initiate in the OR, and then obviously once they're discharged, transfer to different ICU or gen pops. You're going to keep the dressing on. I don't know how many people were there in the past with the previous trial. I wasn't here, but I did hear there was some miscommunication. A lot of things weren't communicated, obviously, so they put it on in the procedure, and then as soon as they were done the procedure, they took it off instead of leaving it on to the general care units. Okay, so that being said, we have over 130 pieces of evidence as it pertains to strict happy prevention in the OR. That's not Mundlicka data, that's AORN, NPIP, randomized controlled trials, key opinion leader studies. I can get you all that stuff. I will leave my cards up here if you'd like. We familiar with these by chance? Has anyone seen the sacral or the heel? Yeah. You want to head down to that? I will go into basic makeup and technology of the dressing. So first thing you'll notice is the initial contact layer is a 5-layer dress. Both our sacral and heels 5-layer dress. We have the Safetex soft silicone, which is the contact layer. Okay. This originated in burn units, NICUs. It's a really very gentle silicone adhesive. Sounds goofy, but we do have it patented. Main thing to remember about this initial contact layer is clean, dry skin. No skin preps, no barriers, nothing like that. It goes directly on. Okay. Another thing that it will do and help prevent is skin stripping, blistering, maceration, things like that. Easy to remove, easy to apply again. Okay. Little background on the Gen Pop units. Every shift, once it's on the patient in ICU and Gen Pop, they are to assess underneath the dressing. You do not need to do that. All you need to do is place, and they're good to go from there. But to ensure there's no pressure injury occurring underneath this dressing, ICUs and general floors are assessing daily. Okay, checking under there, checking the skin, checking the temperature, checking the complexion of the skin, and then once we're good, they apply it back on. Okay, so that's the initial contact layer. Again, no skin stripping, soft silicone, clean, dry skin. In the middle, not going to have a quiz on this, but there's an absorption, spreading, retention layer. Don't need to worry about what those do, but the cool thing with these dressings and why we have the data that we do specific to the sacrum and heel, these dressings internally, which makes ours different as well. The acquisition, spreading, retention layer are all separate. So if you think of like your newer cars that come out, NASCAR or even like Indy cars, when there's a traumatic crash, they hit a wall or something on the highway, what are the new cars made to do? Absorb force and break apart that pressure, right? There's impact zones on every car. Same thing with this, okay? These layers internally are going to move independently to help offset friction, shear, force, all that good stuff, okay? Top layer, not really that important, but it's basically the top contact layer so we can see through, see if there is any drainage or maceration, anything like that. Okay. Used for treatment dressings, if there is drainage coming from underneath, instead of taking off, we can just look at it from the top. Any questions on the actual makeup of the dressing? Not going to be a quiz again, don't worry about it. Okay. So to apply the dressing, I have my butt and my foot. I'll try to get both here. Starting with the sacral dressing. I'm going to make recommendations on where to put it, but at the end of the day, you're doing direct patient care. You know where those bony prominences are. You have the autonomy to place them. What I don't want to see though is them like up here. Okay. Good for me, you know, that means more product, but it's not really doing anything. I want to focus on what's going on. Okay. And we recommend usually starting 2 finger breaths above the ankle. Again, anatomy, patient size, comorbidities, things like that, it's going to differ. Okay. First part about placing the sacral dressing, we take off that middle backing, hold it like a reverse taco. Okay. We have that little valley, 2 finger breaths above. Place, flex, and if we do a fold, clean out the first part of the dressing. Okay. Now from there, we have 2 more backing sides. Pretty easy there. Take this backing off, smooth, this backing off, smooth, and you're done with the set. Bigger weight, patient?
No, wait.
Oh, wait.
I think
I hear you. but-
maybe for some people, Rodika.
Right.
I think many of you worked in ICU, right, where these were placed all the time. I think you just got to communicate with your patient. Like I would be putting Mepilex on 25-year-olds, right? Because it was a standard in ICU. I think you have to communicate really well with them. This is the standard, you know, blah, 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 blah.
And I always think them.
Yeah.
I think this is for protection. And it doesn't like to wash their hair and a hairy butt. And so one size fits all.
Yeah,
No.
that's a legitimate question.
Yeah.
We have 2 sizes.
Oh, okay. Right.
There's a pediatric and an adult.
That's it. So if they have bigger butt, yeah, because one. I know, I just wonder.
Okay.
Yeah, that's true.
They only have one bony prominence area. You focus on the bony prominence, not the surface.
Small.
We're not stocking peds here.
We're not, so we just have these all. Okay.
These are much smaller,
Okay,
and it's, I mean, it would have to be a very frail elderly patient
okay.
for it to work.
Much bigger is not gonna hurt.
Bigger's not gonna hurt. Bigger's not gonna hurt, but just for confusion and sake of the trial, we're just gonna stock this one. Don't send this to any of my people internally, but the bigger patients, more difficult patients, we sometimes see it.
We flip it upside.
There's two here,
Oh, okay, that makes sense.
but that's not part of our IFU data. I can't make a claim against it, but some of our best inventions and improvements in products have come from nurses such as yourself.
Rodica's in charge of supplies.
But
I'm gonna be watching.
for 20 bucks, a couple of these, as opposed to a potential happy state,
Right.
especially within the ICU. They're spending a couple more days, we're talking tens of thousands. That's a goofy figure, I know, but it's all about preventative. I'm good with you. Just don't go off the shoulder blades on specific to say. Yeah.
You know, before we go.
Outpatient, you can, they can take it off if they want. Inpatient, you leave it on. If they're being discharged.
And if the patient is going home, and I mean, honestly, they can just find someone who,
Yeah.
heal up, it's not going to hurt, it's not going to split the skin, it's not going to. With the heel dressing, same concept, but a little bit different. So with the sacral dressing, we have three backings, right? We have 1, 2, 3. Always take off the center, then the sides. We have 5 here, but it's still middle, top, bottom. Okay. If we ever get confused what way to turn it, the wider, fatter, biggest part, whatever you want to call it, is going to wrap malleolus ankle. So that's a good way to remember the top always goes. If you do these, they're up in the middle. Right where we have sort of that default fold, that's where we're going to place. Okay. Get good fiction on that first. Here's the top around the Achilles, here's the bottom. From there, we start from the top. Back in there, wrap, back in there, wrap. Bottom secure. Back to the top of the dressing on itself. Same thing with this one. That's our deal. Okay. Now to assess these, I'm not even going to bother with it because you guys won't be assessed. All you're doing is the plan. Okay. So that is the heel.
What about a patient who's already has some on, who's been down here? We're still gonna have to look at this. Could you show us how?
Sure. Okay. So on the dressings, both the sacral and heel, we have inspection tabs. Those are these little half moon cutouts on the top of the sacrum, and they are on the bottom of the heel. Okay. So what we do is we take our thumb, index finger, back. That's without taking the top off. Make sure we're good. Check. Then from there, rewrap. Dressing will go and stick back to itself. Okay. Wear time up to 7 days. We are at least labeling them. Reason why we're labeling them, I can pass this around too, is either going to put a P or a T. P is going to be for prevention, meaning skin is intact and healthy underneath there. T is going to be for treatment. That's going to tell the clinicians on the discharge units, recovery units, what they need to do with that. If there's a P on it, that means they have to assess data. Okay. If there's a T on it, that means there's something underneath there. They will always default to the wound care orders that did that. So it might be 3-day change, 4-day, always default to the treatment protocols in that. If it's a P, prevention, they need to assess. If it's a T, we leave it alone. Then obviously date as well, because they need to know when the dressing was put on. 7 days is the wear time. Will they get 7 days out of it? Probably not. Sweet spot's going to be 4 to 5 days. Feel like I just spit a lot of stuff at you. Any questions, comments, concerns, criticisms? Anything?
So the label is that right on top of that, we just.
You can put it wherever you want.
Right there?
P.
Okay.
P.
So after I apply, I'm gonna write her there.
You can do before you do that. Completely up to you.
I need a pen and marker.
Might be good to label it before you put it on. Okay,
Yes, I have a, don't do it with a pen. I have a pen.
that's a good question. So asking, is there a chaperone needed to place this on the sacrum? Essentially, yes. It would be another, we're doing it in pre-op, so the patients are alert. It's one of those sensitive areas that, you know, you probably, if it's a male and you're a female or vice versa, that you want to provide that opportunity to at least ask them. And PACU though, if you're just looking at it, like we fall under that umbrella that you don't have to have a chaperone. When they're awake, you do. On the, in like pre-op though,
Like in an actual course, so it's this, you know. We only need it.
so I guess, I mean, I don't want to misspeak towards the policy, but it would be more of a courtesy than that you're gonna offer. Yeah,
So that.
yeah. I mean, if I'm gonna stick something on somebody's coccyx area, at least would say like, hey, do you want me to have somebody else come in with you? You know, like in the heat of the moment though, when you're busy and all that kind of stuff, like if you can remember, you know, I think that's important. But I guess if the policy actually only states, you know, if you're inserting something in the orifice, then, you know, this wouldn't apply. Just don't hang it too low.
Not too high, not too low.
This is specifically for sacrum and heels.
Sacrum and heels.
No elbow.
It can be used in many different applications, just for the sake of simplicity of the trial. Sacrum and
Okay,
I work with other my Michigan satellites. Midland, West Branch, you know, I mean, they do 4x4s, they're prone, they do shoulder blades, all the bony pounds, something on back. Those do general 4x4s. These dressings, the sacral and heel are made up a little bit different, specific to pressure injury prevention. Our traditional treatment dressings, they're great, fine and dandy, but these two have deep defense technology, which is a goofy way of saying we have one-way stretch. Okay, meaning if it's left or right, east and west, it's going to give a little bit. Okay, comfortable for the patient. If they're rolling and moving, it's going to stay intact. Now, to help prevent against that friction, that shear, they're in bed, heels, boosting, things like that. If I go north and south, I cannot do it. Okay, so it's much, much stronger north and south as it is east and west. And that's what differs the sacrum and the heel from the traditional 4x4, 6x6 ovals, things like that.
You put a P or a C, you put a date.
Times, you want times as well, or just date?
Oh, I'm sorry, that was it. I don't know if we have to have time.
To me, if I can speak clearly, P or T and then date.
I guess those patients that come from the floor, if they're assessing and or changing it and they need to put a time because it is a treatment, that they want to know if it's 4 hours from the placement or the 8 hours, that would be more of a specific example if you need a time. Otherwise, for, preventative measures, probably just date and time, or excuse me, just do date and initials, date, whatever,
Date and label.
and label.
Is there documentation somewhere?
There is. So for time purposes, I might leave the recording on and I'll review that and I'll send it out to everybody, but I know our PACU resident also put together some information about like the, the rationale of why we're doing this for perioperative pressure injuries. So I'll let you go ahead, Doc, and then we'll roll back into documentation.
I'm gonna say something really fast because I have a meeting.
Okay. Here, I'm gonna.
Visitor
stop.
bring back. Thank you, I appreciate it. Visitor bring back. Okay.
Thank you, Lee.
Real quickly. We have no texts. Our texts are always at, we have one. They're always at the meeting and they disappear because they don't want to hear everything. Okay, so patients will come back starting Monday, just patients, not visitors, unless the patient has special needs, unless you as a nurse decide you want their family members to help them get undressed and in bed, or they're super duper anxious. Okay, you can make that judgment. You're a nurse, that's easy for you. I support that fully.
Awesome.
Okay, so the patient comes back, you're able to, like Kristen talked about in huddle, we're getting our abuse and neglect screens done, but we're to 40% of them, we're saying the patient unable to answer. So you're able to answer them questions, you're able to not be climbing all over visitors and really get some work done, do a skin assessment, get the Mepilex on in that time, and then use your family tracker to communicate with the visitor in the family waiting room. The call team will be mentioning this when they call the patients, and family waiting will also be mentioning this. And then utilize your techs or night shift, especially during the first case on time starts. Myself and supervisors will be out there early in the week to help make sure we're all moving. But then the visitors can come back and hopefully before the surgeons and anesthesia to help with some questions and education and all that other stuff.
This is just for first cases or
The whole day after, thanks for asking that, after first case starts, work as a team with the techs to go get your patient. Sometimes you only have one pre-op patient, you can go get the patient back, depending on what you have going on.
this can be
Yes. Pre-op callers, yes. And the family waiting room will say it too. Techs will meet them at the red pillar. So that's what you're going to communicate to them. Okay, go.
So we were in a meeting where we were talking about privacy, or we asked, and a lot of times we have medications that families don't want to hear about. Yesterday I asked my patient, when did we last take this Viagra? You know what the answer to me? Never. So it's a lot of privacy, and I am concerned how I'm asking the questions in front of patients and families. Kellogg, since we have two wonderful people from Kellogg here, to work there too. They print out their medications at the front desk, like the clerk, when they check them in, they get their medications. And by the time they get to us in the they fill out when they took their last medication. So why can we introduce that to our unit and save us some time? And once I fill that out in my chart, I can give it to the anesthesia resident, and we will go to the same label instead of asking every single medication, when is the last one they took that?
Kristen has looked this up. She may have some additional info We will, do you want to talk to it or no?
Well, it's just not part of what we can print at the moment. How long can print it? I looked at our can't print it right now, but the thing that we can print, we don't have. Everyone.
I'm saying that's a great idea, but it just. some of it-
Brought up in there. Yeah, I mean, it will definitely involve the.
Yeah.
Would you guys be okay with having?
Only have 30 patients.
Well, they have only one clerk.
We can take that to workload, like more discussion about the ability to do that. The question in chat, which you answered, is family waiting aware of this and everyone on the same page?
No, they are not aware of this, but we can make them aware, like Helen made aware.
What's she talking about? The med list?
No,
Or
not about the
patient
medicine.
How about the?
Just
Yeah.
the visitors coming back.
Yes,
Yes, they are aware.
they will be. I've talked to your boss.
First I'm hearing about it.
Yep, I've talked to your boss. Mhm. I've been talking to her for months. She's on vacation, but she's going to let people make you aware today or tomorrow. We're open to seeing if we can get this printed and doing a small trial of the med issue. May work, may not. We'll take it to workload and I don't know, maybe UBC. Maybe that's a better avenue for UBC, but one of those things. Okay, if you have questions on either trial, this has been discussed. We're going to talk about it again tomorrow. Mepilex will be here tomorrow. We will talk about bring patient back trial tomorrow. It is out there. You've gotten an email. So if you have questions, seek education. Right? You got questions, seek education. Okay. Okay. Thank you. I appreciate it. I'm sorry we held you back so long.
No worries, just makes a shorter presentation.
Go ahead. I think they won't see your face right
Yeah, just stop the
now.
video,
You want to stop the
Yeah.
video?
because that way the camera stops, I think, and then they should still be able to see everything.
See your,
Yeah, because I'm still screen sharing.
can you see, Kristen, are you still on the Zoom? Can you see the slides? Okay, so
Awesome.
it should be good.
Sounds good.
Sorry, go ahead and introduce yourself.
Oh, yeah,
You
yeah.
wanna-
I'm Stu. I'm the PACU resident. I'll be leaving tomorrow. You'll get one of my friends next week. So you'll have a new face in a couple days. But anyway, I've been around. I feel like I know a decent amount of you guys, but I'll just give a brief 10-15 minute presentation on perioperative pressure injury risk factors, because we all have patients to see very shortly as they come out. Let's see if I can advance these slides. Oh yeah, I'm just an anesthesia resident. I don't have any disclosures here. Just today, I'm also an engineer and I have other disclosures, but not for this. But yeah, we'll briefly go over pressure injuries. So everyone's familiar with the acronym at this point, but hospital acquired pressure injury, formerly we called it pressure ulcers, pressure, shear force, both can implement in the development of a hospital acquired pressure injury. Tons of other factors, as I'm sure we've gone over, and as you all know from various levels of schooling, age, immobility, perfusion, nutrition, heme measures, illness severity. I'm sure many of you have work experience outside of the PACU as well, where you've seen this in the ICUs, on the floors, where they're actually more prevalent, I feel like, where you're more in contact with maintaining a higher level of supervision on these hospital acquired pressure injuries. There's 4 main stages, just to go through it. Stage 1, the skin is unbroken but inflamed. Stage 2, the skin is broken to the epidermis or dermis. That's just kind of the layers of where we're at. And then stage 3, the ulcer goes through the subtube fat layer, that little yellow layer there. And then stage 4, stage 3 and 4 are pretty bad. Stage 4, the ulcer extends to the muscle or the bone. And then hopefully we don't see many of those here. just going a little deeper onto stage 3. So also called full thickness skin loss. Stage 4 is full thickness skin loss and tissue loss. Hopefully those are never events. They, as we were talking about earlier, they do have a cost burden on the facility, in addition to the actual patient themselves. So especially with longer hospital stay, pain, infection, and they can be fatal as well. I actually did have a case when I was a med student here, where a patient had a severe enough pressure injury that got infected, reinfected, infected again, and just was a continuous desperate cycle. And then she eventually needed a amputation. But there is a cost component financially as well, where it gets reported to Center for Medicare and Medicaid Services, and it limits reimbursement. I had exact numbers, but it's not terribly important. But otherwise, for a systems-based approach, so what do we do, why we do, right? So I inherited this slide from my other presentations that I've seen before, IHI in particular, but what are we doing here? So risk identification, obviously patients come out with pressure ulcer. We're looking at urology patients specifically in this trial. I think it's a good population to look at because you're in a various amount of positions, whether you're on your like left lateral position, whether you have an arm over because they're trying to reach like the lateral aspect, or if you're in lithotomy and your feet are in boots, then the boots provide a decent amount of padding. However, your heels are still gravity-wise down and dependent. And then there's also other points of pressure injury as well that we worry about when we're back in the OR before we get all situated. And I cover the patient with a bear hugger, and then you can't see anything anymore because everyone's straight. But we look at like the ankles, the knees, the back of the knees, the hips are big ones. Really any bony prominence that you'd be worried about, because gravity never stops and you're always at risk for these pressure ulcers because you're just stagnated in a state of anesthesia. But going through, obviously, we've identified the risks. They're doing a risk assessment right now, and then they're trying to appropriate a preventative strategy and work with patients in the hospital system as well. And I'm sure off this trial, there'll be an evaluation of the outcome and then see what we do if we make any changes, whether it's addition to a barrier or something else. So high risk groups for pressure ulcers, essentially, pretty much it causes an increased risk of a secondary infection, as I mentioned previously, and then also a 2 to 4 aggregate increase in risk of death in our older population, and especially those in ICUs. But the important thing to remember for us while we're here, because we see a mix of healthy patients who come in for like eye procedures, also patients who come in for much more involved procedures, kidney transplants more so come back here, but the pressure ulcers can occur in any patient. It doesn't matter about their age. There are obvious risks for those who are older in physical age, those patients who are obese. Also, importantly, those patients who are malnourished as well here. We see a decent amount of patients who aren't obese and are actually really cachectic. They're still very much at risk. They have very thin, fragile skin layer in between their actual bony prominences, and you actually are you have just as high of a risk, if not more, for those patients as well. Also, a variety of other specific conditions. Those who can't move or change body position themselves, aka those who are under general anesthetic, for example. Those who can't feel pain. So I think that comes up. We see patients with diabetes quite frequently. You can see patients with diabetic neuropathy, among other neuropathic concerns as well. MS, neuropathic pain is very prevalent, so I won't belabor on that point, but patients who are incontinent, patients who are very seriously ill or have had surgery or having surgery, again, as we see a couple of these take back surgeries, and then those who have a poor diet and those who don't drink and eat enough water. As you can imagine, a lot of our patients are NPO for a good reason. However, that can also contribute to the development of a pressure ulcer itself. We talked about patients who are young and old, patients who have a damaged spinal cord. So actually that's one we see pretty much in our neurosurgery population as well. And then also, importantly, we give patients a spinal anesthetic and they come back to the PACU and they're recovering from a spinal, or they have like a thoracic epidural or something. Well, if they're recovering from a spinal anesthetic, they're not really going to have full function of their lower extremities yet. So they're also at higher risk. And then also patients, specifically in the ortho populations, who have a reconstruction or repair of certain joint spaces as well. Just again, high risk groups. I just highlighted the urinary incontinence portion because they're doing this trial on the urology surgical population here. I think the big thing is if you see something, say something like there's obvious things we can try to do about a pressure ulcer, or if you see somebody in pre-op and they're sitting on like the cardiac attachment, well, that's not ideal. We check for that too, or if they're tied up top, I always make a habit of checking to make sure a patient's untied. I just try and limit the amount of time that they're spent on something gravity dependent wise. There's a lot of text on this slide. Essentially, there's the big thing is consider pressure ulcers for everyone, is kind of the overarching theme of this slide. Different people have different risk factors. We went over the risk factors. There's a lot of different scales to assess risk for a pressure ulcer. I think just being aware that it can be a large detriment to patients and how they experience their patient care, and also financially to the hospitals well, is kind of the big thing. Preoperative risk factors, kind of gone over many of these, but just kind of highlighting specific things as well. We talked about spinal cord injuries, we talked about prior injuries, bony prominences has come up a couple times already. Hemodialysis, specifically line strains, et cetera. So I think when you have an A-line, specifically, sometimes the cables get wrapped around. I try and always use an arm board for my patients. And then also with the pullback syringe as well, you don't want them like laying back on that. For IVs, just making sure you know where the stopcock is to make sure it's not digging into the patient, for example, and causing a skin injury there. We talked about limited mobility briefly with the spinal example. I mentioned diabetic neuropathy infections as well, Charcot joint arthropathy, and then poor nutritional status leads to poor wound healing. And then just a couple of intraoperative risk factors, because I'm in the OR most days. I worry about friction. What are we rubbing them against? We're moving them from the OR stretcher that I bring them back in on to the in-room stretcher on like a hover mat or something. What's actually rubbing against, or are we using a draw sheet, which is kind of rubbing right against their skin sometimes too. We're moving them back and forth. Again, multiple surgeries. Extended length of OR time is a big thing as well. If one thing goes unchecked, like these white snaps on some of these IVs, and it can just be digging in, that's a risk as well. Positioning device is a big one. I mentioned lithotomy positioning as well with the stirrups boots. Spider limb positioning, or for patients in a beast chair as well, are also big issues. So if you have a patient that's like right hand over on like left lateral and right hand over their head, then you worry about gravity dependence there as well. Anesthetic agents. So if I'm doing an RSI and I'm not using rocuronium and I'm using 6-anicoline, for example, patients will have some fasciculations. They might say that they're sore afterward, but they're also at higher risk for pressure ulcers from just them moving around causes other things to move around. And then also on emergence, patients can wake up, as we know, a little wild sometimes. We don't get a lot of deep extubations out here to this PACU, but on the mod side, that's a little bit more prevalent. With vasoconstrictive medications, I've pushed a decent amount of pressors back here in the last 2 weeks. So you're reducing, you're increasing tone and then reducing blood flow to certain other areas. So you get hypoxic tissue, and that can lead to tissue death to some degree as well. So you always have to be in mind, like if they're on pressors, I kind of think about where exactly they're perfusing, how are they perfusing, and then also low arterial perfusion states as well, bypass, ECMO. For ECMO in particular, I think one important thing is like where the cannulas are, where are they going, and then when we flip people around for x-rays and things like that, making sure there's still nothing underneath them after the actual imaging is done. Post-operative risk factors a little bit more important for us. Mechanical vent patients, intubated and sedated patients usually don't come here, they go to the ICUs. But I briefly mentioned vasopressors. Interestingly, if a patient's sedated and they're on propofol, propofol infusion syndrome does exist. I've seen it a couple times. You essentially have a very malnourished patient at the end of the day. At that point, we follow on their triglycerides for these kind of patients, and then that can actually lead to worsening wound complications, among other things. And overall, all these things contribute to increasing length of stay. We went over what Mepilex is, so I'll just briefly cut my presentation short there and open the floor to any questions, should there be any. All righty, back to work.
I have one question.
How are you doing?
So we used to have this patients who go to ICU, they go to ICU. Why do we have to remove? I mean, if they don't go to ICU, we have to remove this.
We're not doing that anymore.
We're not doing it, just leave it.
Leave it. All of these dressings we're leaving. That was an old trial and it was back in like 2018.
So what was that?
It was just a different, I don't even know. I'm not gonna get into it, but yeah, it kind of lost track and steam, I think, and like,
Only like 3 people knew about it.
like by whole, or like the stakeholders limit, yeah. So,
Third one.
Some of the docs, they were unfamiliar with it, so they're like,
Information
Oh, okay.
sensitive.
Oh, good. Okay.
Steady flow of communication.
Thank you. That's perfect.
Okay.
Any other questions on the chat? I'm gonna, like, if anybody still wants to hang out, I'm just gonna pull up these slides for the documentation portion. I did send them out, I think a week ago or so. And I just want to make sure we kind of narrow in the importance of the documentation. I think. We got through the first 2. Okay, so on this slide, what's the RN role in pre-op? Essentially, you're just gonna stay under that soft silicone dressing that it was applied. And then you have to state the location. So left heel, right heel, sacrum. And that's pretty much it. That's gonna be in your pre-op checklist.
Oh,
Under that soft silicone dressing, it's about, I don't know, 3/4 of the way down in the checklist. And you just put that it was applied, left and right heel, sacrum, and that's it for pre-op. Am I missing anything with that? And then PACU, oh, that was my, yeah, so the right side of the screen, you see that it'll flow and it shows up under the Braden risk interventions. I know Kristen just did a couple more screenshots that we'll send out to everybody. But it does populate then when it was applied, the location, and then especially then for the floors, like they'll have to follow up with you know, the overall assessment of like peeling back that little layer.
You also.
We're not assessing, we're
Not
just
at all.
saying
Sorry.
that it's in place.
Okay.
We don't have to peel it back in a sec.
No,
No. There's nothing in this row that you can document about an assessment other than peeling it back. Yes, you can say to remove or replace or apply.
changed.
But
Yeah.
pretty changed, yeah.
So there might be some things that come up, obviously, in this trial that we do have to tweak our view and off time, like we'll see. But if you guys have, you know, scenarios or suggestions or things that come up, like you got to let us know so we can take it to off time or whatever. And then to coordinate, you know, any changes necessary. But those are just the brief little screenshots of documentation. So I think one thing to keep in mind is that it is different from the last time we did it, that we are keeping them on. They're staying in place. PACU does not have a responsibility of knowing, do they stay or do they go or anything, keep them on. So I think that's that's good, you know, from our perspective of work, whatnot.
All of ours are gonna be.
For the most part, yeah, yeah. That,
If they already have like a wound and they have the dressing on.
some of the questions, if you guys can't hear, are like, are essentially are all of ours gonna be Ps? Yes and no. I mean, they're gonna be for prevention, but you might have one that says a T for treatment. Anything else?
It does not really fit the chaperone policy. The policy says for sensitive nursing care, including putting medical equipment onto the urethra or rectum, which we're not doing any of those. So it's basically like perineal care.
So it's high enough above the rectum that you don't have to have a chaperone.
Yes. So
Okay,
it's not only about.
That's good.
Yes,
But on.
We're not putting
We're not
anything in.
going any of those places.
we're not going inside any orifice.
right. That was good clarification. Okay,
Thank you.
that was a lot. This is a long one. Thanks, guys, everybody on Zoom. If you have any other questions, let us know. Yeah, I'll go back and take attendance.
All right. Thank you for coming.